OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube movies and shows. OCT, or optical coherence tomography, is a non-invasive imaging technology used to obtain high-resolution cross-sectional images of the retina. OCT is absolutely fascinating, aiding optometrists to not only save eyes, but also save lives. Today, we have a repeat guest, Pennsylvania-based optometric physician, Dr. Greg Caldwell. Dr. Caldwell is an OCT educator and innovator. Thank you, Dr. Caldwell, for joining me today.
Yeah, Kerry, thank you for having me. Truly an honor and a pleasure to be here.
So let's talk OCT. What is it and why do you love this technology so much?
Yeah, OCT, Kerry, has really been a game changer. You got to remember when I graduated in 1995, we didn't have it. We had to examine the retina, how to use different ways of light, 78, 90. Ocular coherence tomography came along, definitely a game changer. In a sense, we can say it's an MRI, but it has nothing to do with magnets. It's just the way the light. I really don't even know how the instrument works, to tell you the truth. I just know how to interpret them. I know it's coherent light. And depending on the different tissues, you get hypofluorescence or hyperfluorescence, and then you can really tell what's going on, basically, but with the mechanics of the eye and what you're seeing.
OCT has really changed optometry, for so much of the better, and it really helps our patients. We can now see down to 5 or 6 microns with OCT, and with spectral domain, we're going to be able to see 1 micron. So we're kind of put in a position where we're going to see disease way before other primary care doctors can see disease.
Oh, absolutely. When we're starting to do that now, right? We see, especially in the patient with diabetes, we're picking up the capillary changes that are out there, macular degeneration. We're picking up, the drusen formation that's out there. So you are 100% correct. We're picking up diabetic retinopathy before it's really retinopathy that you would see with a 78 or 90, the classic, what I would say maybe the macro changes that we were taught in school, the dot and blot hemorrhages and the exudate. Now we can start seeing the micro changes that are out there.
And soon we're going to be the first doctors that are going to help diagnose Alzheimer's sooner. There's some changes on OCT as far as Alzheimer's. If you could talk a little bit about that.
Yeah. So, the eye is fascinating, right? It really is connected to just about everything that's out there. We talk of, skin, and then we have the vasculature that we're talking about here with diabetes. And now you're just talking the neurological side of it. And there's a part of the eye that's called the ganglion cell and the ganglion cell body. And its axon goes all the way, back into the brain, deep into the brain. And whenever it becomes sick or traumatized, it atrophies away. So the ganglion cell complex, which can be measured within the OCT, can take on some certain patterns that are out there. Believe it or not, just recently they're saying that, people that have, pituitary adenomas, and we're used to picking that up maybe with a confrontation field, bitemporal hemianopia, and we do a visual field. It's showing, so bitemporal, binasal can show up maybe 2 to 3 years earlier, but even before the visual field defect, which then goes back to your original question here, the neurological side with regarding, Alzheimer's and dementia, and maybe helping the docs with the diagnosis, and then how's the treatment going with the progression. So really exciting stuff that's out there for the future.
Yeah, and we could see that the choroid is starting to get thinner. Those blood vessels are dropping out, and some of the capillaries start dropping out. So right now, there's nothing specific that says, okay, well, this is Alzheimer's. But hopefully, we're going to get there within the next 5 years, and neurologists are going to be referring to us for OCTs to confirm whether or not somebody may have Alzheimer's. So if we look at the future of OCT, how can OCT maybe be used during surgery?
Well, basically where it's being used for surgery right now is in the macular hole type of situation, when they're doing retinal membrane peels and looking at the hole, just to make sure that they're getting the position of that macula. So, just before and after surgery, especially after surgery, to see how that hole is, and do they have to go in and reposition. So, that's really some new cutting edge, using it during surgery. Just in retina surgery is basically what it is. That's really where the OCT shines. But this OCT, it's, you got anterior segment now. So we're looking at it with cornea. We're looking at it just anterior chamber, everything that's going on with the anterior chamber, and then going back to the retina. So basically where it's being used in surgery would be back in the retina side.
We're almost like we're a pathologist, the way we could look at the retina and the nerve tissue.
Yeah, you nailed it. This is pathology in a sense, live pathology in a sense. So just a different form of it.
And now we have OCT angiography, which came out around 2014. Explain what OCT angiography is and how that could help us with diagnosing different diseases in patients.
Yeah, so we always say that the crime must fit the punishment. So there's 2 types of OCTs if you really kind of want to think about it. There's your B scan OCT, which optometrists, when I do a lecture and you ask how many people have OCTs, that's probably about 70 to 90%, depending on what audience you're doing. 70 to 90% will raise their hand saying that they have an OCT. It's the B scan. It's kind of that cross sectional that we're used to seeing. And you're right. In 2014, what happened is with spectral domain and being able to get these instruments to get up to about 70,000 scans per second, what they were able to do with the technology is what's moving versus not moving, which in that case, the blood would be moving, the red blood cells and the white blood cells, and they're able to track movement and subtract out what's not moving, and you get a nice image of the capillaries of the inner retina, particularly that superficial and deep plexus. Now, we always say the crime must fit the punishment, and the diabetes is a capillary disease. So we're really getting some early detection with capillary dropout before you get the B scan changes. Same thing with macular degeneration. We're able to get choroidal neovascular membranes, especially those occult ones, growing down below the RPE, because fluorescein angiography can't see below the RPE. And we're starting to pick up on these capillaries from macular degeneration. So really, the 2 big diseases where OCT angiography shines, where the crime fits the punishment, would be diabetes and macular degeneration.
And if you could tell us the difference between spectral domain OCT and swept source.
Yeah, so the difference is just the amount of, in a sense, resolution. especially, I mean, even step back to time domain. Time domain was, the Zeiss, the Stratus. It was scanning, I forget, it's 15 or 16,000 scans per second. And we were getting about 15 to 16 microns of resolution. And just as a reminder out there, if we take a millimeter and cut it 1,000 times, and I always say to the patient, a slice of bologna and cut it 1,000 times, the time domain got us down to about 15 to 16 microns. Spatial domain gets us down to 5 to 6 microns. That was whenever they were able to get it up to about 70,000 scans per second. And just by using different algorithms and increased scans per second, now we're able to, swept source is able to get down to 1 micron worth of resolution. So that's really, really cool that's out there. So 15 down to 5 to 6 and swept source getting down to 1 micron worth of resolution.
So we could see the vitreous, the retina, the inner and outer layer of the retina, the RPE, the choroid with the OCT. But people are very interested in the ellipsome layer of the OCT. And sometimes, or, Jerry Sherman called it the photoreceptor integrity line. And it's basically the line of the photoreceptors. And if you want to share your screen for a second so our audience could see what we're talking about, because I know a lot of people, especially when we're talking with some of the students, and even when we're talking to patients, and we're trying to explain to them why they might have lost vision, and that line is very important. So if you could take us through that and what it is.
So I'm going to just jump right to the ellipsoid zone, or here it's labeled in the picture as the photoreceptor integrity line. But what I want to point out right here, all the way from this external limiting membrane, all the way down through to the anterior surface of this RPE complex, that's the photoreceptor. And so, the name changed. You're correct. It was always known as the photoreceptor integrity line, the inner and outer segment of the photoreceptor. And then it changed to be the ellipsoid zone. So the ellipsoid zone, as you can see, courses all the way across this OCT scan here, and it changed the ellipsoid zone. So I wanted to do a little bit of digging on that, and just found some papers out there and found out, why does this ellipsoid zone, as you can see here, it's lighting up as a brighter color, and it really is the mitochondria of the photoreceptor. And right above it, this black zone, it's called the myoid zone. It doesn't get talked about it that much, but that's where the endoplasmic reticulum and the Golgi apparatus of the photoreceptor. So, the ellipsoid zone is extremely important. We can see when it becomes oxidatively stressed, it starts to fade. It starts to, in a sense, gray out. And that's never good, because we know the mitochondria are the powerhouses of the cell. So basically, we're looking right at the mitochondria of the photoreceptors.
And if we're looking at the cones, show people where the cones would be and how far they extend up.
Yeah. So
to before.
Yeah. So basically, from the external limiting membrane to that anterior surface of the RPE, it's a mix of rods and cones. But as we know, as we get to the foveola here, we kind of see this little gradual uptake. And we know that the foveola, if not all, is predominantly the cones. And when you look at the morphology of a cone versus a rod, a cone is really tall and thin, and a rod is a little bit shorter. So that's why when you look at this OCT scan, back in the day, we thought maybe it was edema, but really now, because of the high resolution getting down to these 5 to 6 microns, we could see this little uptake, and we're looking at how these tall cones, and that's just normal physiology and pathology there, just because the cones are tall and skinny.
If you could show us some of the other anatomy, where the choroid is, where the vitreous is, and the inner part of the retina.
Yeah. So I'm going to start out here because really, whenever I look at OCTs, I always like looking at the choroid. The choroid is not, talked about that much in lectures. I try to bring it because the choroid can swell, the choroid can atrophy. And so it's just anywhere down below this RPE complex. And you can just kind of see, it's kind of, hazy down in this area. So we got the choroid. And then on a really good resolution, that's why this is labeled as the RPE complex, because you can get this hyper, then this black band, and then, kind of the inner side of the RPE. Then we jump up to the ellipsoid zone, the myoid zone, the external limiting membrane, and then black or nuclear bodies, and then plexiform layer. But between the plexiform layer and the next nuclear layer, this is a loose adhesion. So the inner retina is right here. The outer retina is down here. And there's actually just a loose association. So that's why when you start getting some traction, as you can kind of see right here, there's a little bit of traction, but not enough to create a separation. But that's why you'll see that lamellar holes, if it's opening up, you'll see that retinal schisis is usually between the inner retina here and the outer retina. When you have the capillaries that are leaking from diabetes, you usually start to see some of that edema, that exudate, that hemorrhage accumulate in between that inner and outer retina, because again, there's a loose association. And you mentioned about, where's the vitreous? The vitreous is out here, this black space. You could see here that there's a little bit of vitreous pulling up. We would call that a vitreomacular adhesion. And if you really want to help out with the anatomy, you really don't see the optic nerve here, but you could tell where this retinal nerve fiber layer is really thick over here compared to the other side, that this is the nasal side. The optic nerve would be over here just by looking at this picture.
Show us where the macular pigment would be.
Yeah, the macular pigment is in the inner retina of the macula. So this whole picture is the macula. Remember, there's the fovea, and then there's the parafovea, and then there's the peri, and those are all parts of the macula. So this whole area is the macula. The pigment likes to be in the inner retina, the layers of Henle. And so just up here in this inner layer is where the macular pigment, where lutein, zeaxanthin, and mesozeaxanthin are laid out.
And you could see how that macular pigment being there is a protection for the choriocapillaris, the RPE, and the photoreceptors. But you mentioned before about mitochondria. What kind of nutrients can actually help the mitochondria? Not so much, not only in the retina, but in the whole body. But if it's helping in one part of the body, there's mitochondria, of course, throughout the body. Probably the most, I believe, is in the heart.
Yeah. And I would agree with you. The most is in the heart, but they're also right there in the eye. Well, actually, I'm going to point out another area where mitochondria hang out. We're talking about this RPE complex down here in the most outer part of the RPE. There are mitochondria, and we're talking about the mitochondria here of the photoreceptors. And one of my favorite molecules to help out, or nutraceuticals out there, is resveratrol. Resveratrol has been very researched multiple times to be very protective of the mitochondria. And it's also, in a sense, a natural anti-VEGF. So resveratrol, along with others, but resveratrol is the one that gets talked about the most.
And also CoQ10 is very protective for the mitochondria.
Absolutely, yes.
So let's leave that picture up there and show me, when do people start having damage to their visual acuity? What has to happen for people to really start to have poor vision? What has to be damaged?
Well, the crime must fit the punishment. You'll hear me say that all the time. So if a patient is going to have vision loss, it usually has to start with that photoreceptors breaking down. And that photoreceptor is out here in the outer retina. Now, remember, the photoreceptor is down here. That's why this little pit is here, kind of pushing the light away to trying to push those structures away to let that light get down to this cone. The cones, which give us that most acute vision, and this area right here is telling that E from the F, the O from a G. Obviously, if the inner retina gets destroyed and those connections can't be there, then obviously the photoreceptor could be perfectly healthy. But we usually can predict what's happening with the patient's acuity by looking here at this outer retina, especially the mitochondria, that ellipsoid zone. It starts to break down and starts to fade. You're going to start seeing a drop in vision. So this outer retina is where the photoreceptors are, especially those cones, are pretty important to being able to tell what's going on with the patient's acuity.
Now, if the ellipsoid zone is intact, but the external limiting membrane is damaged, what kind of vision would you predict with that type of patient?
Yeah, I don't think it would be compromised too bad. If there's some type of pathology to cause that external limiting membrane to break down, but if that ellipsoid zone is intact, 20/25 at worst, maybe, because that photoreceptor is still intact, and it's a membrane, so the rest of the nuclear and the plexiform layers and the wiring would most likely be intact. So I wouldn't expect too much of a breakdown.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
We're going to talk about this later and show some pictures, but for an occult neovascular membrane, where would that be living?
Yeah, occult, it's one of those tricky ones, right? It's down below the RPE. So you see the RPE complex here. So it would be down in the choroid, just lurking right below that RPE complex.
So let's switch to the OCT angiography, and let's show the different capillaries, the capillary plexuses, if you could go to that.
Yeah, I certainly can. So this is one of my, favorite slides here. It kind of transitions right into what we're looking at using this anatomy. We see the fovea where we just were. Here would be a good representation of the inner retina getting to the outer retina. And then we have that capillaris, that choriocapillaris. That's pretty much just nothing but a bunch of large and small blood vessels. It's a bloodbath down there. And you can see here that it's trying to show in this cartoon the superficial capillaries. And if I just animate this, you could see here that we have the capillaries being imaged now, which is just amazing what we can do. This is a OCT that it scans. It has to scan at least 70,000 scans per second. And again, with that 70,000 scans per second, what's moving are red and white blood cells and all the other constituents of blood. And if you subtract out what's not moving, now you can see the superficial plexus and the deep plexus. This is where diabetes would be important. And then you get out to those photoreceptors, which, they don't have any blood vessels. They get it from above and they get it from down below, as we're seeing here, from all the blood from the choriocapillaris. So these are some really cool images, and we can point them out and put them on side by side. And you can see here using the B scan, we're talking about the superficial plexus being here, going a little bit deeper, showing the deep capillary plexus. Then you're getting out to the photoreceptors, about where those mitochondria are, that ellipsoid zone. And again, getting nutrients from above and getting nutrients from down below here, looking at the choriocapillaris. So just amazing, the technology. Again, I graduated in 1995, and to be able to sit here and look at images like this is just wonderful.
I think it's worth repeating. Show us the layers where you would see diabetes, dot and blot hemorrhages, exudates. And so start with the superficial capillary plexus and show us what pathology we would expect in each one of these four sections.
Yes, so diabetes, capillary disease, right? That's why we always hear neuropathy, we hear nephropathy, the kidneys being involved, and then retinopathy, and the retinopathy being damage to the capillaries. So diabetes, far and foremost, we always got to remember, is a capillary disease. It's the disease of those tiny, tiny blood vessels. And then when you're looking at the eye, in this 4 pictures that we're showing here, there's really only 3 vasculatures: the superficial, deep, and then the choriocapillaris. And really, it's this inner retina, superficial retina, where the capillary dropout can occur. There's areas of non-flow, and the capillaries could start to leak, or they get these little bulges called microaneurysms. So it's really, if we're doing diabetes, Kerry, it's these first 2 images, the superficial and deep capillaries of the inner retina. It's really the inner retina disease.
And if we start seeing blood vessels in the outer retina and squiggly blood vessels in the choriocapillaris, what is that telling us?
Yeah, it's probably some form of the first and most common disease would be macular degeneration. I mean, it could be a few other things, but it's going to be macular degeneration off the bat.
Tell us the difference between a fluorescein angiography, OCT angiography, the pluses and the minuses of each one. And do we need both?
Well, right off the bat, we're going to need both, but it's going to be probably depending on what stage of the disease we're in. We as optometrists love to be able to do early detection. So the difference is, right off the bat, is we hear OCT angiography, but no dye is needed. That's, again, I'm going to repeat that. No dye is needed. No injection is needed. It's just all based on that 70,000 scans per second. You know, some instruments I'm hearing are getting up to 120,000 scans per second, and they might already be there. And with that being said, subtracting out what's moving and non-moving. So again, OCT angiography, no injection. Fluorescein angiography, you need to have an injection of the sodium fluorescein. You wait a few seconds for it to circulate through. And then basically, you know, it's working on whether the capillaries are leaking. And as you take pictures over time, for lack of a better term, you're able to see that kind of that puddle develop from the leaking. So one of the advantages of OCT angiography is being able to see these occult choroidal neovascular membranes before they leak. And the sodium fluorescein cannot see below the RPE. So being able to see below the RPE is some of the major advantages that are out there. But, you know, once the patient starts to bleed, it's difficult to see what's happening with an OCT angiography. They've already bled, so now it's time to get the fluorescein angiography, and then that's where the advantages come out. But then once treatment starts, they both have their advantages and disadvantages, as in a sense, you know, the patients are getting those anti-VEGF injections.
You did a beautiful job of giving us a background and setting it up. Let's see some photographs of people that actually have diabetes and are showing some changes in OCT angiography, such as increased foveal avascular zone or capillary dropout. If you could show us some of those photographs.
Yeah, so let me just kind of see here. Let me just kind of show you right off the bat so we have a good understanding of what's happening. This was an extern of mine, 25-year-old man, perfectly healthy here. And where we can image the optic nerve, and we can see the radial peripapillary capillaries. And here are the 4 images that I just showed you on this scan, that superficial deep. You can see it's a little bit thicker on the nasal side, and then the temporal side gets a little thinner. This is all normal vasculature here to be able to compare.
If you could go back just a second.
Yeah.
On the slide to the right, the first picture, you see those red dots, those little red dots of blood or blood vessels. Tell us what that is and how that could help us.
Yeah, so doing OCT angiography, what we're able to do is pick up blood flow. And this is showing the blood flow. The red right here, these are the dots I hope you're referencing, is that this is the blood flow of the, which is normal, of the inner retina. You can see the blood flow of the outer retina. And then again, you can see that highly vascularized choriocapillaris down here. So just looking at all of this flow and using this red, this is just, again, what normal vasculature should look like. So good pointing that out as we go forward here.
And if we see abnormal blood flow, abnormal blood vessels, or we're seeing leaking, what will happen? Will it just be in the place where it doesn't belong? Will it be, or will it be like, look like it's spilt and like spilt milk, but red?
Yeah, so yeah, a few things. Yeah, these took a little while to learn how to really interpret it. All of those come into play depending on the disease. But in diabetes, we get capillary shutdown. So all of a sudden, you might be coming across and you see blood, and all of a sudden there's no flow. So that would be a sign maybe of dropout or capillary closure. Sometimes you can get retinal neo, intraretinal neo, and then that would light up as a big complex. The choriocapillaris, when we're talking about macular degeneration, usually we see it kind of in a sense, hit the button here, kind of going into a sense up into the RPE, as if one of those drusenoid detachments, pigmented epithelial detachment from a drusen, that drusen becomes vascularized, not a good sign. That's someone I'd like to follow a little bit closer. So it could be dropout, it could be flow where you shouldn't see it. So,
well, you have a great way of explaining things. Thank you for that, Dr. Caldwell. So let's go to diabetes now.
Yeah. So here's one, one of my favorites, because back in the day, we would say, the patient was referred in, they needed to have a diabetic eye exam. And we would dilate them. We would use all the tools that we had, 78s and 90s, take a photograph. And we would say that this patient would have no diabetic retinopathy. But again, it's a capillary disease. And being able to look at the capillaries has really showed us that we could pick up on the disease. And one of my favorite is, this area is black on purpose. This is the foveal avascular zone. You see this FAZ, foveal avascular zone. There's no blood vessels in there. Again, for the reason that we want to get all that light rays down to those cones and photoreceptors to be interpreted. Is that an E? Is that an F? And so that was purposely made for us to not have blood vessels there. But just to the outer edge, that's one of the thinnest areas of capillaries. If you think about it, we're going from no capillaries to capillaries. So this is one of the thinnest areas in the body or in the eye of capillaries. So if diabetes is affecting this outer ring, or this little early ring around here, is important. So here's a patient here. You can see a little microaneurysm up top here, but you could start to see the capillaries dropping out. Now, I just want to point out real quickly that a lot of the colleagues will ask, well, what's the normal size of this foveoavascular zone? And I'm going to throw caution to the wind to try not to, when it comes to structure, try to get something that's normal. What you want to look for is symmetry. I've seen patients come in with 0.443 and 0.447. What you're starting to look for, if one is 0.44 and the other one is, say, 0.54, then what you want to look for is the expansion. So maybe, we're looking at a foveoavascular zone here. We're seeing damage. It's starting to expand. So we're looking for that asymmetry of this foveoavascular zones. And I have a couple examples that I can show of that.
And capillary dropout, if you could show us the capillary dropout and decrease of vessel density.
Sure. Yeah. And I have some slides that I can show the decrease of the vessel density. But right here, you can see this little black area out here of where there should be capillaries flowing. And then right in this area of the foveoavascular zone, if you look through this area, we could see it's pretty well networked, getting some dropout where this black area is, a little thinning here. This is a patient with diabetes, and over here we would say that this patient is free of diabetic retinopathy. But again, knowing that it's a capillary disease, we can now label this as diabetic retinopathy in its very earliest stages. And a lot of times these patients come in with a hemoglobin A1C that's a 7.8 or an 8. And maybe here we'd be encouraging them like, okay, you get another year out of it. But over here, we really want to drive down that hemoglobin A1C.
And many times we'll see this capillary dropout and the patient has no idea that they're diabetic.
That is, yep, that is correct. You know, the definitely back in the day, I know when I graduated in 1995, we would pick up more and more patients, from an eye exam with diabetes. Not as common, but certainly it's out there nowadays. So we definitely always got to keep our heightened senses up. And you were asking about the capillary density dropout. Blue in this case is not good. That means there's no flow. And this is one of my favorite slides to show because you could see that the blue increases as we go across. So we're measuring that vessel density. You can see the different numbers, but more blue is over here in this 2017 photo. But what we're looking at here is as we come across, remember, we're talking diabetes. So we're going to look between this inner and outer retina. And here's the B scan. That looks pretty good as we go across. Maybe a little bit of a ripple effect here. But as we keep coming across, if I could just show this little hyper reflective area, and you can see how it's blocking the signal. And here's another hyper reflective area blocking the signal. Now, on an OCT, that's either exudate or blood. You'd have to zoom in maybe with a 78 or 90 or look on your photograph. And obviously, if it's white-ish, it's going to be an exudate. If it's red, it's going to be blood. You can't really differentiate. But my point is, we'd be saying here, look at this maybe early, or this is early diabetic retinopathy. But look at how much capillary dropout we had to have. And we'd be picking that up a lot early on those superficial and deep plexus as we were showing, as we could see here in this patient. If you want me to do this, or
Sure.
So yeah, so here is just kind of a patient that came in. This is a patient of mine that walked in and they needed to have their diabetic exam. I'm just going to focus on this top part up here. And if you just look at that inner and outer retina, you could see where we would look for any type of retinopathy. And obviously the 78 and 90 and the photograph all look good. But I'm going to jump down here, Kerry, on this part of this, the scan and printout, foveal avascular zone, looking at the area. And if you look and see how this one is 0.35 and 0.2, again, it's not the number that we want to look at, but see how the asymmetry, how that right one is larger. That now clues me into really opening up this angiography, looking at it over here. You can see it's not round, it's irregular. You could see dropout in this area of thinnest capillaries, the foveal avascular zone, or just outside the foveal avascular zone. And then as we move out, you can see areas of dropout where this black is here, a little bit of dropout here. But let me put these I don't have them side by side, but you could go down right here and you could see that this one is definitely enlarged, and we're picking up diabetes. This is a patient that before 2014, before angiography was out, they would come in, we would say back to the primary care doctor, the endocrinologist, this patient does not have diabetic retinopathy, but now the technology is allowing us to see it, and that there truly is.
In the photograph on the left and the upper part of the wellness report, you could see the columns. If you could look at those columns, what is that showing us in these pictures? If you could review that again, which you mentioned it before. Yes.
These ones right here? Yeah. So these columns, because of this cut right here, you can see this is a horizontal cut and this is a vertical cut. So we're actually cutting down through the retina this way. And as we cut down, and so this horizontal cut, I'm going to go back to the horizontal cut. That horizontal cut is going right through here. So we're not hitting that many blood vessels. That's why you don't get that many horizontal cuts. So these are actually, since this is the vertical cut, you're hitting a major blood vessel here of the superior retina, another blood vessel here in the superior retina. And that's why on these vertical cuts, you get these columns, because it's like this blood vessel right here. As we cut down through, this blood vessel has blood in it. And what it's doing is blocking the signal. So you're getting kind of that hyporeflective column. And that's a normal finding here. And this is a normal finding because of these blood vessels, the major, branches of the superior and inferior retina.
And before you showed exudates or hemorrhages that were abnormal, how can you tell the difference, or you can't?
Well, it depends. And this one here, because these are so superficial, you could see that this is like where the normal anatomy is. And again, it goes back to years of interpretation, knowing that, down in this area, like maybe here, this might be an early diabetic change, but that would be kind of hard to say. But it's between that inner and outer retina where we start to look for those changes. So as we go across this way, we would say this is a pretty clean looking B scan, but the OCTA here is definitely showing some dropout.
Thanks for clarifying that. And let's turn our attention. Do you have any other pictures of diabetes?
Sure. Here's another patient here. And again, I quickly like to look down here, and I can see this 0.29, this 0.38. There's that 0.1 difference. And again, I'm really going to focus on the one that's enlarging. And that would be, you could see the dropout that's occurring to this patient. And this would be a patient, maybe right here, Kerry, you can see this inner and outer retina. You can see a little bit of capillary, a little bit of hyperfluorescent. That's probably some early changes, but man, it's not really convincing. You can see here this little vitreous is coming down, creating a little distortion here. So that's a little vitreomacular traction. But as we come across here, this isn't screaming diabetes with the B scan. And you can see here, this is normal. Here's that blood vessel, right? We're probably catching, this one here, and you're picking up on that's hyporeflective column and that hyporeflective column. So these are all normal. Here's a vitreomacular adhesion coming down. We call that an adhesion because there's no change to the morphology of the retina. This one becomes traction because you can see there's a little bit of a little puckering up there. So this is a vitreomacular traction, vitreomacular adhesion, but clean, but then jumping down again to the capillary images. You could see what's happening. Dropout in this right eye and a little dropout here, but it's more advanced in the left eye. And that's another little pearls I like pointing out when interpreting OCTs. So a lot of times we get this, this green and yellow and red and blue disease. And sometimes you'll see like these GCCs, they'll be lighting up as yellow or red. And it might be because it says 80, and 80 would be, wow, that's pretty red. But if it's 80, 80, 80, 80, 80, 80, I would just say that's probably someone that's a high myope. And it's just physiologically normal for them. So I'm all about asymmetry. When there's asymmetry out there, start scratching your head.
And what did you say the magic number for you is of the area? 10, 14, 8? What's the magic number?
Yeah, when I start seeing, so over here, the magic number, when we're talking about foveal avascular zone, I don't really focus on this millimeter squared. Like, this is 30, this is 30. If it's 10 and 10,
But
or if it's 40 and 40, it's the difference right there.
What's the magic number for the difference?
The 10, the 0.110. Yeah.
Thank you for that.
Yeah, absolutely. Yep.
And do you have any more data?
Yeah. Let me just show you this one here real quick. So this is nice because you can take the images of the optic nerve and montage and see what's going on. But you can see here the capillary dropout, some microaneurysms. You start turning on you click on this, you measure the foveal avascular zone. I like showing this because click on this little button here, gives you the en face. And you can see maybe a little bit of some retinopathy occurring, these hyperreflective areas, especially in this area up here. And then you go over and it's matching right where that capillary dropout is. And if you come down, look at the B scan, maybe a little bit of diabetic retinopathy here and here. Still, you got some pretty good blood flow. That's the patient's right eye. You jump over to the left eye, click on the on-phos. You can start seeing a lot of these little hyper reflective areas. Again, you can't tell blood versus exudate, but I want to go back. I want to show you something here. Look at this here, and you can see a little bit of white spots. And I go forward here, you can see some white spots, but I would say those are pretty equal. But when you jump over to the capillary and start seeing the dropout in this foveoavascular zone, I'm gonna go one more click here. I think I have it here. And now when you look at the right eye compared to this left eye, you can see this is 0.23, this is 0.45, basically doubled in size of this foveoavascular zone. You can see the capillary dropout in both eyes, but you could really see how this left eye is under assault of diabetes.
And you can see there's many microaneurysms.
Absolutely. Yep.
If you could point out some of those.
Here's one here. Here's one here. This is a microaneurysm here. So these are pretty classic, 3 of them popping out there. So good eye, Kerry. Very good eye.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.